Pediatric Dental Association of Malaysia. Am I right? Is that the right term?
Yes, it's the Malaysian Association of Pediatric
Malaysian
Dentistry.
Association of Pediatric
Dentistry, yes.
Dentistry. Sorry. I was invited by Dr. Yogesh and Dr. Annapurni quite some time back, and I forgot about it. And the topic they asked me to choose, I chose a topic that most time that when pediatricians and pediatric dentists often refer each other. These are the one that children with special need. And when I did some background homework on it, most of the articles and review articles were all from the Pediatric Dental Journal. And correct me if I'm wrong, that I think so-called special need care came about in Malaysia back in 2011. And I think one of the earlier hospitals was Hospital Serdang. I think the doctor in charge wrote a paper, Dr. Hamza. Subsequent to that, I think more hospitals have it. I mean, worldwide special care need also started only in the early 2000s. I think Australia, Canada, about 2003 and 2008. If I'm wrong, please correct me. I'm just reading from that actually. So what I'm going to just go through here is just to discuss the definition of special care children, and also the common conditions that come under this, and what are the features and how we would like to manage. Basically, is sedation during the procedures and post procedure care actually. With that, allow me to share the slides. I'm not really familiar with this. If we repeat, can you see?
Yes, Dr. Selva, we can see. Yeah, we can see it. Yes.
Dentistry for a child with special needs. The pearls and pitfalls. It's most of them a lot of pearls. Not much of pitfalls actually. Just basic. I couldn't get any data from Malaysia. I saw a paper from India. 21 million people in India suffer from one other kind of disability, equal by 2.1% of their population, and 12.6 million are males. This includes children and also adults. 93 million were females. The number of disabled persons is highest in the age group of 10 to 19, almost about 46.2, I think is 100,000, not 100,000, yeah. And 20.42 children were disabled. Is 1 in every 100. And then the percentage of disability, hearing was about 23%, vision 30%, movement 10%, and multiple disability 7% actually. There was another in America, 56 million have some form of type of disability condition, and 25 million Americans have severe disability. As you know, America is mainly managed by insurance care. Most of these individuals live in community-based centers or at home with their families. What is the definition of special healthcare need individuals? This is from the American Academy of Pediatric Dentistry, 2016. Individuals who are those any physical, developmental, mental, sensory, behavioral, cognitive, and emotional impairment, or any condition limiting that requires medical management, healthcare intervention, or use of some specialized services or programs actually. Just to make it simple, a child with physical disability but no intellectual disability often uses wheelchair. That's something that we can imagine ourselves. A child with intellectual disability but no physical disability often is autism. And a child with intellectual and physical disability is called a developmental delay. Most often is global delay, and most often quite a number of children with intellectual disability have often no underlying cause. I'll come back to that later. One of the common cause of low mental retardation or intellectual disability is trisomy 21 or Down syndrome. The other one is Fragile X syndrome. And then there are also children with complex medical condition, like what I often refer to the pediatric dentist is my patients on the nephrotic syndrome or on chronic other treatment like cyclosporine, which can cause a lot of abnormalities in the gums. Apart from that, there are also children, with complex medical condition, hemophilia, leukemias. There are all these coagulation problems. They also need to have common care between the pediatrician, the primary care pediatrician, and the attending pediatric dentist or a dentist, a general practitioner. And we have child who have learning disability. This is very wide range. These are children who can't pay attention. In fact, autism can also come into here. And there's another one, child with disability, but no disability with high need for services. And then like asthma. The other thing I could think about here is that cystic fibrosis. I happened to see a few last week. Cystic fibrosis often, and these are patients who have problem when we are treating them, especially if they need anesthesia, be it sedation or general anesthesia. And then apart from that, there's the normal child who has exceptional fear for dentists, dental phobia, and uncooperative. Even I think almost 40% of adults, mainly females, who have this dental phobia. I think even though I'm not a female, I'm one of them actually. Okay, child with special needs. What are the obstacles? This physical accessibility. If you notice, I think I might be right to say that most of our facilities have not got enough ramps or enough dedicated lane made for these people, including where they park and anything. This itself hampers the patient coming with their parents or they themselves to come to a medical healthcare facility. The other thing is that lack of financial resources. This again, looking at some articles that I saw, in America is basically insurance based and it's going to be difficult. Fortunately, in Malaysia, it's not. But still, we have a large number of population in B40 who can't afford this, and often they have problems coming to attention of dental health care and delay in dental care. Lack of effective communication, both the caregivers and their parents and also the patient. And often there's language and cultural considerations that we often see problem. And here, I might just go on talking actually. Here, for example, if you have a child with physical disability, and also, for example, like cerebral palsy, and if the unfortunate child is an Orang Asli, previously I was working in Pahang. Certain parts of areas of most Orang Asli, they don't even come to see us. They don't have accessibility to the nearest healthcare center, financial resources, and of course, this language and cultural consideration is very, very in them. If you have a child with a cleft lip and cleft palate, they often tell them that they don't want to get it repaired because it's their ancestors' way of doing things, and we have a lot of time problem getting them into healthcare. And of course, together with that, if a child has cerebral palsy, their dental care is quite poor, and they often come in late. And most of the time, what we do is that we catch them when they come for other problems. When they come in for pneumonia, needing admission, then we see them. They have poor dental care. We often refer to our pediatric dental colleagues actually. And then, of course, the priority and attitude of the importance of oral health care, behavior management issue, and limited transportation. If places like in Pahang, or I might be in Sarawak and Sabah, similar actually. There are medical issues with children with special care, special needs. One is the mental capabilities, behavior issue, mobility problems, neuromuscular problems, and uncontrolled body movement. If I were to say mental capabilities, mainly children with an autistic spectrum disorder, whereby they have math problem, or children with learning disorder, we have difficulty to even examine them, to get adequate history. Therefore, in keeping a record for these patients is very much important. At the first encounter, we need to get very detailed medical history and family history from the parents and document it. If it's possible, we often give them a book and we write them there. Everything is better to write all the things there, so that the next encounter with another doctor or medical officer, or even a dental officer, then all the records are there. It is very important, actually. Similarly, we're talking about behavioral issues, also same thing. Mobility problems. It is mainly with patients with cerebral palsy. We need to identify when they're spastic diplegic. Most of them, cerebral palsy, they have involvement of the upper limbs. They can be one side or both upper limbs, or the worst one is the quadriplegic, which are often immobilized, and these are the people often get more dental problems, actually. Neuromuscular problems, these are the ones that it's a bit different from cerebral palsy. Neuromuscular problem is the one that patients can come with either condition like Duchenne muscular dystrophy, where they have problems of using the peripheral muscles, and some of them, the spinal muscular atrophy. They have several types. Those who survive often have problems with swallowing, and these are issues when it comes to dentition, and they can have a lot of problems with the gum, periodontal disease, and also dental hygiene itself. And when it comes to when we are managing them, again, there's a lot of problem because they have poor coordination of swallowing, actually. And uncontrolled body movement. Uncontrolled body movement is seen particularly in cerebral palsy, where they have this episodic cerebral palsy. Most often, it's the cerebral palsy that children develop after in the neonatal period, when they have severe jaundice. I mean, nowadays we hardly see them. If you're 20 years back, if you're working in the interior of Sabah, Sarawak, or even Pahang, when they come in late, you can get kernicterus, and most often these children will have this kind of ethetoid cerebral palsy. Okay, apart from that, we also can have children with cardiac issues, congenital cardiac disease, gastroesophageal reflux, which can occur by itself or together with cerebral palsies. Seizure can occur with cerebral palsies, even with kids with autism. Visual impairment, hearing loss, deafness, or all these things can occur on its own with a child with special care need, or in combination with others like autism, cerebral palsy, and global developmental delay. This latex allergy is another thing that when we often use them, they can also develop latex allergy. So when we are dealing with them, we are wearing gloves, we need to ask them that whether they have such latex allergy. Although in Malaysia, it's not very common to have latex allergy, but in the papers from the Western world, there's quite often a history of latex allergy. For an example is that children with spina bifida, they often have this, especially when we are dealing with them, when we do clean intermittent catheterization of the bladder, and often they have this problem with latex allergy. And this latex allergy also can occur anywhere else. I got this from one of the pediatric dentists, one of the articles. Children with special needs, the treatment principles. Treating the teeth is easy, but the ability to treat whatever the teeth is attached to can be quite difficult. What I understand is that treating the children or the individual who has a lot of problems when they are in the special care need category. So basic principle of pediatric dental care apply to as to all children, and we know that even a normal child, well-developed child, also has problems when they attend dental care. So as I said earlier, obtaining a thorough review medical history is very, very important. And the dentist must be comfortable of obtaining medical consults from the treating primary pediatricians actually. And vice versa, I think the pediatricians will refer to the pediatric dentist colleagues. The referrals should be thorough, because if you're seeing for the first time, I think the referrals should not be just kindly see, please treat the dental caries or the gingivitis. Rather than that, I think it should be written in detail about a child's history, especially if the child has in the kind of special care group, cerebral palsy, all forms of autism, any chronic medical condition that the pediatric dentists need to know when they're treating should be included in the record. Most of the pediatricians practice by writing in the small book that the patients or the caregivers carry, and this is a practice that should be encouraged. And then we also should consider the patient's ability to maintain oral hygiene with the corporate. Even though we see the special care children, as I said earlier, some of them who do not have who have normal brain development and they are capable, most often they would follow the orders. However, despite saying that, but if they have problems of swallowing and everything, then it's going to be a problem again. When we see them again, even in our own pediatric clinic, these kind of children would not tolerate the normal long waiting hours of a normal child. So we have to consider the length of appointment, even have to consider when we are going to see. Most children, they will tire themselves towards the later part of the day. So it is better to see them in the morning, preferably, and you should have a short examination, short procedure time, and early in the day. And may need to also, our regular clinic, we need to also alter them. And most of the time, I'm sure parents are always in the procedure of the operation when we are doing the operation. So I'm not going to go, if the list is very exhaustive in this child with special care needs, but I'm just going to touch a few. One is cerebral palsy. As I say, cerebral palsy children are the child with normal mental development. It's only the physical disability. Child with autism has a normal physical development, but it's the brain development that is the one disability. Child with Down syndrome, we can categorize both together. Of course, the other one is the intellectual disability or mental retardation, or we call mental handicap. And here, a few things: Fragile X syndrome, fetal alcohol syndrome, and Rett syndrome, which are quite quite common in this group actually. Now, cerebral palsy is a disorder of posture and movement caused by a non-progressive abnormality of the immature brain. It is non-progressive. The damage has been done. Most often is seen in the premature neonates, whereby it can be an antenatal, during labor, or postnatal insult to the developing of the growing brain. And the insult one is there, but it's non-progressive. And so it's about 1 to 2.4 cases per thousand. The low birth weight infants are the one at risk. And these disabilities may occur, and they are permanent. This, as I said, it depends on the extent of the insult. They can have seizures, they can have visual impairment, squint or strabismus. They have problems with hand-eye coordination. They can have auditory impairment. They also, even despite saying that most of the time, but severe ones, they also can have intellectual disability, learning disability, and behavioral problems, those severe ones actually. As a forms of cerebral palsy, spastic diplegic, quadriplegic, chorioathetoid cerebral palsy, to name a few actually. I mean, I'm just looking at the management from the medical point of view. I'm not going to dwell detail in the dental management. So again, these are things that we need to see. Sometimes it crosses our mind, and our budget is not there. Even in a normal pediatric clinic, we don't have a proper, clear pathway for moving them through the treatment setting, including our normal clinic. And another thing I directed with the availability of now pediatric rehabilitation physicians is very, very much important to get them involved early in the management of these kind of children. Sometimes we have to treat them on a wheelchair. So I know the dentists use a sliding board. Short appointments, these are one of uncontrolled movements, and we have to control them by using muscle relaxant, sedation. Most often, when patients with cerebral palsy, if they cannot be managed by the normal conventional sedation that we use at our procedure room, then we have to think of general anesthesia. So most often when they refer to the pediatricians or the anesthetists, the patients have to go through rigorous examination and history taking, and then assign them whether they go into the ASA classification 1 or 2 or 3, whether the risk of the general anesthesia outweighs, the benefit outweighs the risk actually. But sometimes when you have to do a lot of severe clearance, you have to use the general anesthesia. All right. That's a bit on Down syndrome. Now the next one is on cerebral palsy. The next is Down syndrome or trisomy 21. This is one of the commonest chromosomal abnormality resulting in intellectual disability. With child with mental handicap, mental retardation, Down syndrome is the highest on the list, and the prevalence is about 1 in 800 births. The risk of this chromosome disorder increases as the maternal age has been known. Or at 20 years, about 1 in 1,600, 35, 1 in 370, and it goes on further up. When you have one offspring with Down syndrome, the risk of having another child with trisomy 21 is about 1 in 100. The sex ratio, it differs from paper to paper, but normally it's about 3 males to 2 females. Actually, this is just a brief. Of course, there's more to Down syndrome, and I don't want to dwell in the classical features of Down syndrome. I didn't even put a image or a diagram. Classical Down syndrome is that it shouldn't be using the word mongoloid. It's not very good. Slanting eyes, brachycephaly, short stubby fingers, and then you get a simian crease, first foot or first digit, the white palm space, and then child with trisomy 21. Apart from the physical appearance and the mental handicap, mental retardation, they also have a lot of other medical complications, namely from head to toe. They can have problems with, most important when we're talking about dental, is that they can have atlantoaxial laxity and mobility. So when we manage, there's a risk of injuring the cervical spine, and they can be rendered paraplegic actually. Some of them can have this spontaneously also. The other thing is that if you have a lot of congenital heart disease, they have kind of problems with their lungs, the airways, with the gut. They can have a lot of problems with duodenal atresia and duodenal stenosis. Going down first, they can have problem with hip dislocation and blood malignancies, especially acute lymphoblastic leukemia. All these are things that patients with Down syndrome can have. Not all, some. The other one is that we have in pediatrics, we have a regular checkup. We see them, we screen them, and we have every 3 monthly and 6 monthly yearly follow-up. Yearly, we have to, even at the beginning, we have to do a tracing for the thyroid function test, because quite a number of them can hypothyroidism, even though being down trisomy 21, if treat the hypothyroidism earlier, the outcome is better. The other one I want to say about obstructive sleep apnea. About 30% of the patients. And of course, dentition, they have problem with irregular placement of teeth, hypoplasia, to name a few. But the studies, the papers in the dental, they say that they have, I mean, if you compare the normal children population, the incidence of caries is almost similar or less, but they have increased periodontal disease. How do you manage? The management concern, apart from that, trisomy 21 itself, they have compromised immune system. They often tend to come in, especially in the earlier part of the life, come in with frequent history of infection, high rate of middle ear infection, pneumonias actually, and this also predisposes them to other problems. And they also have epilepsy, they got higher rate of diabetes, as I said, leukemia and hypothyroidism. And as patients with trisomy 21, they have problems with communication, we need to have a lot of time to allow to communicate and slowly explain to the parents and the child. Then some of them can understand, and most can understand. And as you know, as we have done very well, most of our trisomy 21, even in Malaysia, they go on to live above 40 and 50 years old. I won't dwell into the atlantoaxial instability. It's important when we are doing procedures. By it, the dentists, or even we as pediatricians, especially when we are intubating and everything, we must be very careful of the positioning. These I got from the dental review. I was told that they normally we see 3 monthly recalls for scaling and cleaning, teach them good home care, teach the caregivers good home care and good toothbrush. Some say electric toothbrush. I would like to hear from the pediatric dentist on that. Patient and parent or caregiver education is important, especially an approach at behavioral development level. Since I've spoken about cerebral palsy and trisomy 21, something that we need to discuss now is that as most of these patients do well, they go beyond 12 years and go into the adolescent and teenage and adulthood. This is a transition that we need to be very careful, that we need to teach the caregivers and everything. Because the moment they leave us at 18 years old, and when they go into the care of the physicians or the family medicine specialists, the care tends to be truncated there, because they're often very attached to the pediatricians. These are things that what we need. We are proposing, actually, we already proposed a transition care from pediatric to adolescent to adulthood, actually. And most of the time, the children who suffer is the children with chronic problems, the ones that I mentioned, and also like leukemias, renal problems, the one that they tend to miss when they move into adulthood, along with dental care. So now the third, I'm going to talk a bit on autism or autism spectrum disorder, and some may say pervasive syndrome disorder. And autism is impairment in social reciprocity. To make it simple, I mean, these children or individuals, they do not have this interaction between the one another. They have very poor eye contact. They seem to be living in their own world. There's a lot of criteria. They have impairment in communication, which makes it very difficult for us to treat them. They have also certain set values or repeated movements and narrow interests and the rituals. And these are the things that they tend to have it frequently, and when we disrupt them, they can go into what we call a meltdown. And they have limited social motivation and emotional recognition. These are the ones that on the extreme worst part of the spectrum. We also have what we call Aspergers Syndrome. Now, we often hear a lot of celebrities, even scientists, who go into this kind of what you call a category. I'm sure most of you would have seen this movie called Rain Man, where Tom Cruise has this ability to remember cards and everything. His form of Asperger syndrome. Asperger, normally they have very good in spatial thinking and mathematical analysis, actually. So Asperger have little impairment in language or cognition, they are the higher functioning form of autism actually. As I said earlier, Rett syndrome, this is often mostly affects girls actually. It's an X-linked dominant disorder. It is rare, but if you get it, it's the worst form actually. And normally the clinical onset you don't see at birth. You often see about 6 to 18 months, then some abnormal movement. They tend to do what we call milking of the hand. And these are the things that we need to see. And later on, they will completely lost their purposeful hand use, spasticity, seizures, and mental retardation actually. And normally autism also we can't diagnose them at birth or early childhood, 6 to 8 months. We can we should be able to make the diagnosis by using the MCHAT score, which is just a screening score in our home-based start at about 24. We shouldn't exceed before 30 months. Saying that quite some of autism tend to be diagnosed very much later. But it's okay. In autism, if you're talking about dental care or even pediatric care, we need to have, that's why in most of our pediatric clinic, we tend to see them on a different day when there's less patients. We tend to see the same doctors if you have the same medical officer, same pediatrician, and the same staff, the staff nurses and everything, because these people will slowly learn to have the same routine actually, and must be less noisy, less tactile and sensory stimulation actually. Again, they also have poor muscle tone, poor coordination and drooling problems. So again, issues with oral hygiene and also procedures with the oral cavity, and again on sedation. And they tend to prefer soft food and sweetened foods, and very much sweetened foods can cause dental caries. And they have poor tongue coordination, and if you see, most of the children like to keep their food in the mouth, called pouching in the mouth, and then again, this is not very good for your dental hygiene. And poor caries and poor diet. And during procedures, they may need sedation, because as they cannot understand and cannot follow, they may need sedation for certain procedures actually. Now, that is what we normally see as a child with special care needs with all those problems with mental and physical disabilities. I just like to touch a bit on pediatric cancers because this is very important, because basically the blood malignancies, acute leukemias, it's about 30% for all the childhood cancers, lymphomas, and the other brain tumor. Of course, the rest is kidney tumors and other solid organ tumors, which is not much important. But especially if you have diagnosed a child with acute lymphoblastic leukemia or a lymphoma, you, as a pediatrician, you need to put them on a chemotherapy plan. And we missed it. Often we are told to refer to the pediatric dental colleagues to have the assessment of the oral cavity, look for caries and everything, whereby we should do the clearance before we start the chemotherapy. Because once you start the chemotherapy, most of the chemotherapy drugs are very, very toxic, and they render them immunosuppressed, and at that point, or they have coagulation problem at that point, if you want to go for clearance, would be difficult. The other thing is that once you've started the chemotherapy and you have multiple caries, this can cause infection, and it can put them going into septicemia. So it is preferable for them to refer to the pediatric dental colleagues earlier for dental clearance. Saying that, sometimes in between we do have patients with dental caries or dental problems, and the best time is to discuss with the pediatric hemato-oncologist when the child's white cell count is better, the ANC is not low, and they are not having any chemotherapy. That's the best time for us to do any dental procedures or clearance. Finally, I think I'm coming to the end of my talk. Sedation. This is something that most often Sometimes we are called, but most of the time our dental colleagues are fantastic. They do their own sedation. This is what I read from the American Academy of Pediatrics, Dentists, and also the American Academy of Pediatric recommendation called moderate sedation, or is also known as conscious sedation, whereby the patients are given sedation. They are still conscious. They can follow simple commands by, like, especially if you're doing a dental procedure, they open your mouth. These are the children. Slightly bigger children can command better. So you just give them slight sedation that they won't move, struggle. Smaller children, they tend to cry during this, but they're still manageable. And 70% of pediatric dentists use oral sedation, and the common drug is chlorohydrate. This is what even I use for my procedures. Even like renal biopsy, if a child can be sedated by chlorohydrate, I don't go beyond that. Apart from that, then we use the benzodiazepine, namely Midazolam, Midazolam, or I use we don't use morphine for children for pediatric, but I use Midazolam. And from the studies, 20% of pediatric dentists Midazolam. And the goals for sedation, I think you might be familiar with that. Just to facilitate and augment the provision of quality care when you do the procedure, minimize extremes of disruptive behavior. You can use them for children with cerebral palsy, autism, even those with mild or moderate learning disabilities. And it promotes a very positive psychological response to the treatment and promotes patient welfare and safety, because these drugs are quite relatively safe. And then after procedure, they can return to the physiological state earlier, and they can be discharged on the same day after your office or the very next day. Most of the time, these are done on where the patients can be discharged once their physiological state, their BP, heart rate, their oxygen saturation is back to normal, and they're well, and they can be discharged. Patients who need for continuous sedation, conscious sedation, or the moderate sedation are those who cannot cooperate due to the lack of the physiological, psychological, or emotional maturity, like autism, or those who have cognitive, physical, and mental disability. Of course, there are other indications. Since we're talking about child with special need, I just included these two. The routes most often is oral or enteral. And even though the depth of sedation is not totally dependent on the route, most of us from the papers that enteral sedation itself is good enough. Sometimes we have to go to the parenteral IV, diazepam or midazolam. Okay, that is okay. The drugs, a bit on drugs. Chlorohydrate is a classical pediatric sedation that we use. It's a sedative hypnotic, actually. If you use a dosage between 25 to 30 milligram or 50 every 6 to 8 hourly, that's for hypnosis. We use them when our patients are on non-invasive ventilation. We use them. For sedation, it's between 50 milligram per dose. I don't go beyond 1 gram, even though for bigger children, they say can give 2 grams actually. And chlorohydrate tends to give a baseline sedation, and the child is just there, and then we can always, if they wake up, we can give a bit of small doses of IV midazolam. So not much of side effects, except some papers report GI upset actually, and they can get nausea and vomiting. That's when we can use antihistamines, diphenhydramine. Side effect is sedation, of course, and when used together with chlorohydrate, we can combat the nausea. It can be used alone or together with chlorohydrate and diphenhydramine. The last one is the benzodiazepine, which we commonly use. Midazolam is most popular. It's quite stable for the heart, and there's a wide margin of safety. On and off, you can see some paradoxical reaction, what we call nightmare. The children will start, instead of sleeping and sedated, they will start jumping around. This can occur, and not to worry, there's always a reversal agent available, flumanazole. The dosage of benzodiazepine that in my practice, I give for my patients and procedures, we use about 0.1 to 0.4 milligram. That's about maximum that we go on actually. We don't go beyond 5 for small 5 milligram or 10 milligram for bigger children actually. And that's all. Thank you very much. Before I end, I was told by the organizers that I need to inform that 12th of June, you have 16th of June 2021. There's a talk by Dr. Nurul Wafa Hussein, who's a consultant child and adolescent psychiatrist at the Malacca Hospital. And she'll be talking on behavior expectation and management children with ASD and ADHD. That's the reason why I didn't talk about hyperactive or ADHD children in my talk. And the moderator will be the pediatric dental specialist, Dr. Tavamala Marimutu from Hospital Malacca. Thank you very much. Dr. Yogis?
Yeah, thank you, Dr. Selva, for a very informative talk just now. You've covered quite extensively on the various aspects of the special needs for us. Thank you very much for that. Do we have any questions? Let me check the chat box. Well, Dr. Silva, just to the earliest part of the talk, you mentioned about special needs. Dr. Noraini had commented in the chat box that for the apparently, I mean, it appears that in Malaysia is the 4th country to recognize special needs as a specialty after Brazil, Australia, and New Zealand. So we are quite ahead, I guess, in the world in terms of recognizing special
I saw that actually in the paper. There's one paper I couldn't open up in ResearchGate. It was done by a few of our your colleagues from University of Malaya. Yes.
Thank you. Thank you, Dr. Noraini, for that comment. We have a question here for you, Dr. Selva, by Dr. Tavamala. She says, good afternoon, Dr. Selva. Thank you for the comprehensive talk. At the beginning of your lecture, you mentioned the use of cyclosporin in transplant patients, which causes gingival hyperplasia.
Okay.
I very much agree to it, as we do face such problems. May I know the reason why tacrolimus is not used?
Okay. I wanted to say I completely forgot about it. Basically, tacrolimus, cyclosporin, or what we call is calcineurin inhibitor, cyclosporin. Previously, cyclosporin was used in renal transplant, but now we no longer use for renal transplant, and we are using tacrolimus. And in fact, tacrolimus is one of the immunosuppressant along with prednisolone, and sometimes we add on mycophenol mofetil. So tacrolimus, we don't see much of gingival hyperplasia, hypertrophy in our renal transplant patients. But unfortunately, as a pediatric nephrologist, I know not many, and the term I'm sure you've heard of steroid-resistant nephrotic syndrome. These are children who do not respond to prednisolone well, or the frequent relapses, they respond to prednisolone, but they become very, very Cushingoid. And we have to look for steroid-sparing agents. And a few of the drugs that we use for steroid-sparing agents are cyclosporin, tacrolimus, and mycophenol mofetil. But tacrolimus is very, very expensive. In our guideline, we use cyclosporin first. That's the reason why among the nephrotic syndromes, we use cyclosporin. I've learned from experience now, if I see a child with nephrotic syndrome to begin, sometimes I like to disturb my pediatric dental colleagues. I refer them to early, especially those with poor dental hygiene, poor gingival condition, so that they can be seen by the pediatric dental colleagues so that they can treat. And if I were to use what we call cyclosporin, I think it's less. I think I need the response from Dr. Tavamala. And then the other thing is that nifedipine itself can cause gingival nifedipine, yes, can cause gingival hypertrophy. Most of the patients who are steroid resistant or frequently, they are also hypertensive, and it's also similar to to the transplant patients. So I mean, if it's seen earlier, I tend to switch off to other antihypertensive. Have I answered your question, Dr. Talmala?
We will wait for Dr. Tamala. Do you want to turn
Dr.
on your
Yogis, how about your response actually?
Uh, yes.
Do you see a lot of children in your practice with gingival hypertrophy secondary to cyclosporine? That's one of the worrying things that I don't like to use cyclosporine. I mean, the rest of the side effects we can monitor by the levels and everything. One is very, very difficult, especially children with malaligned teeth and their gingival hypertrophy is bad. Is that right for me to say
Yes.
that?
Yes, Dr. Selva, especially when they've got malaligned teeth. And it's very difficult to manage with the gingival hyperplasia, because once it's hypertrophic, then the oral
Yes,
hygiene is
really bad.
yeah, it's very bad. So
So for us, especially the pediatric nephrologists, what is the advice if we were to start on cyclosporine? At the present moment, cyclosporine is already approved, so we tend to use a lot of cyclosporine. Tacrolimus, you need to get certain places KPK. That's why it's very difficult. And not all patients respond to tacrolimus or cyclosporine actually. And the other thing is that cyclosporine, we don't use it for like 3-4 months. We tend to use it minimum 2 years. And if the patient rendered protein free, we tend to use them longer, because we don't. If not, these children or teenagers can go into renal impairment. You see. So, what is your advice from either one of you actually?
I will speak first, then maybe I will ask one
Yeah.
of the others, somebody else also to comment.
Yeah.
For what I see is, most of the time, by the time we dentists see the patients, the gingival hyperplasia has already progressed quite a bit. So it would be good maybe for us to actually start seeing the patients early on. Means we get an early referral, so we can actually introduce their good oral hygiene into their routine before or even as they are starting with their therapy. I think that's one of the
Something that is good to do a prospective study, looking at their dental hygiene before and after we starting the cyclosporine, and see whether who are the one don't develop very bad gingival hyperplasia after the cyclosporine therapy. Thank you.
Yeah, they're not all develop severe hyperplasia though.
Yeah.
Maybe anyone else wants to comment, you can unmute and give your comment as well, please.
Dr. Yogis, there's another question from Dr. Jacqueline Ng.
Yes, I will read the question here. Thank you, Dr. Silva, for the very informative talk. May I know what are the considerations or risks for patients with special needs before we advise general anesthesia for the patient?
Okay. Yes. I'm not very. I can't really remember the ASA classification, but especially if you're talking about history. The history is very important. I'm talking about cerebral palsy kids. If you look at their records, if they're coming recurrent aspiration, recurrent convulsion, and these are the children that if we were to definitely these kids would not do well in our normal sedation. The sedation practice, what I mentioned, the one normally you all use with the yogis, right? Isn't it?
Oftentimes in hospital practice, we will use a mix of midazolam or just pure chlorohydrate sometimes. And then we've got nitrous oxide as well, but
Yes,
not really suitable
I didn't touch on nitrous oxide because I'm not very familiar with that actually.
But it's not very suitable though for many of the special needs because they can't keep the nose piece on. So
yes.
parenteral,
So in consideration with that, this is very important if you were to send them for thinking of general anesthesia. We need to look at the airways, especially those who have recurrent intubation and everything. They can have narrowed airways, mild subglottic stenosis. All these things are very important. One thing good is that most of the time, most hospital right now, if we were to refer for an elective general anesthesia, the anesthetist and the anesthetic team would see them in a clinic and they would go through everything, and if they're not happy, normally they'll call back the general pediatrician to investigate further. For example, they're not happy with their lungs. They say, can you look at it and treat the asthma or the hyperactive airway first before they induce? Or this particular patient has some problems, especially in the drug history. If they have any form of reaction to any of the inducting agents, then they have to look on others. Or they have any cardiac problems. All these things are important, because most of the time these children with special care needs, especially those with neuromuscular problems, they can have sometimes cardiac problem together. Thank you.
Okay, thank you, Dr. Selva. We have another question from Ima Malik.
Right.
She says, good afternoon, Dr. Selva. Thank you for your lecture. May I know what is your recommendation for a pediatric patient who is on biphosphonate pamidronate infusion and require dental treatment such as tooth extraction? Any precautions or advice to consider?
Right. I must admit, I have no experience on using pamidronate infusion, neither biphosphonates. With the permission of the organizers, I'll get back to this. And then, because I know some of my pediatric endocrinology colleagues use that, I must say I don't have actually. In fact, at the back of my mind, I can't even recall anything. I have to do some reading. If I'm not, it won't be nice if I were to give any information which is not right, actually. I'm very sorry, Dr. Emma Malik. Yeah.
Okay, thank you, Dr. Selva. Yeah. We can always post a reply later in our social media, in our Facebook and things. Thank you. So do we have any more questions for Dr. Selva? Okay, I don't see any more questions. You seem to have finished up all our questions. I have a few messages saying that it's been a very informative talk, Dr. Selva, and many of our pediatric dental colleagues are very happy with this lecture talk that you've given us this afternoon. So on behalf of the
Malaysian... Sorry, before
Dr. Selva.
Yes. I mean, sorry, I'm always having some ideas. Actually, I'm quite surprised to see that. I thought the special care thing, Dr. Noraini mentioned special care thing in Malaysia. Only we are the number 4. Is that all the hospitals with pediatric dentists have this, or only certain hospitals?
Okay, may I answer that?
Yes,
Dr. Noraini.
May I answer that?
Yeah, sure, Dr. Noraini.
Okay, thank you, Dr. Selva, for a very excellent presentation.
Yeah. Yes, Dr. Noraini. Go ahead, Dr. Noraini.
Sorry?
Go ahead, I'm listening. Yeah.
Yeah, all right. Thank you for an excellent presentation. Okay, number 4, that was in the early 2000s, yeah? We started our special needs dentistry for adults. I put up the papers in 2007, 2008. Because of for children, the pediatric dentist will attend to all these children with special needs. But after some time, we see all these children into becoming adults, and we just could not cope. That's why we put up. And by then, in 2004, already 3 countries in the world, Brazil, Australia, and New Zealand, recognizing that as a specialty. So we just follow suit. And that's how we started the special needs dentistry or special care dentistry for adults. But the children are still being seen by the pediatric dentists.
Dr. Noraini, I share the same problem with you, actually. Even, for example, pediatric, our age is 18, especially those who are managing chronic, like pediatric nephrology and everything. We tend to send to adults actually 18 years old, but there are some pediatric nephrology patients with special care, autism, cerebral palsy. Those days when the resources were very poor, we tend not to treat them. So now as we get better, these children grow up into become adolescents, and some of them are handicapped with their ongoing problem. So that's why our colleagues, the pediatric adolescent pediatricians, come into picture. And what we propose, we have already done a proposal paper to the ministry. By right, what we are asking is a transition clinic, whereby it happens in most of the Western countries. I'm not sure about pediatric dentistry, for others, whereby we see them together, because these children are quite, I'm sure you'll agree with me, they're quite close with us, with our nurses and everything. When they go into adulthood, they are not chronologically the adults actually, but they are, otherwise they are not. And that's where the problem starts. When they go into adulthood, they tend to miss the care. And that's when our pediatric adolescent comes in. They run a transition clinic together with the adult colleagues, be it the physician, be it the surgeon, and then subsequent to that, the patients will go into the care of these our adult colleagues. And there should be some adult physicians, adult dentists who have special interest in these kind of problems. Do they have it in Malaysia right now, or
Yeah.
it goes back?
Okay, at the moment we have only a handful of special needs dentists.
Yeah.
Not every hospital in the country. No, actually, the pediatric dentists are hospital based. So
Yes.
not every hospital where we are placed that we have the special needs dentist for the adult. So we started with regions, of course, Central, KL and Serdang, and then we have the North and South and East Malaysia. And now we have more. So some of the bigger state hospitals have the special needs dentists. But still, you are lucky. You have the transition, adolescent.
No, Doctor, it's on our own initiative.
Yeah, that's why for us, we do the transition clinic. So we invite our special needs dentists. For example, if we are last time we were in a PITS Institute, so we invite the special needs based in HKL to come with us for the transition period. Because these children, they are difficult to adapt to somebody new. Yeah.
Yes.
So we are the one running the transition. We do not have the adolescent dental specialists. Okay.
Something even adolescent pediatricians are not many. So like in Selayang,
I know. Yes.
Previously when I was in Kuantan, I used to run it myself actually, and then place. But sadly, unfortunately, most of them tend to drop out from the adult clinics and they get missed away. Actually, see, that's a sad thing. I'm sure you're seeing the same thing, right?
Yes.
Something that ministry, I think something that both the Malaysian Pediatric Association and the Malaysian Pediatric Dental Association can work together. And I would like to tell you that my fellow colleague, Dr. Tiaga, some of you might know, he's the Alustar pediatrician. He would be good to come and talk to you about this adolescent care for your children actually. He's the best person for chronic care for adolescents actually. Thank you.
Yeah, thank you.
Thank you, Dr. Silva, and thank you for the suggestion of a speaker for us. I think we will likely take that up. And I have a comment here from Dr. Anna, who said, excellent discussion for this session. And we should seriously look into some studies for children undergoing transplant, and also to provide oral hygiene support for these children. This is something for our association to look into it together with the universities to consider. And I agree with Dr. Anna as well, Dr. Silva. I think we should look into it because by seeing them earlier, we actually can prevent a lot more problems for them than seeing them when things have already become worse. So with that, I don't see any more questions. I would like to thank you, Dr. Silva, for a very good session, a very good informative session. Thank you very much for coming over and
My pleasure.
And giving us a talk, in your personal time. We very much appreciate it, and we hope to be able to connect with you again soon sometime. Thank you very much from all of us.
Thank you.
Thank you, and thank you to all the
Have a pleasant
attendees.
weekend. Thank you. Bye.
Okay, bye. And thank you to all the attendees. We have the link in the chat box for the attendance. So you could put in your attendance forms at the link, and we will send you a certificate later.